three of you. I mean, you can say no. By all means, say no.
Yeah, that's fine.
I don't mind either way, whatever's easier.
If we do microphones,
amazing.
it might be a bit easier because I feel like, yeah, it's just more interactive. So I'm just going to start off. So yeah, it's calcium and vitamin D homeostasis today, so an endo topic. And I'm just going to start off with SBA. So if you guys read that and have a think, and then say any suggestions you have.
I always find it a bit strange that, like, in endo, they teach you loads about like diabetes and thyroid disease, but they don't actually teach you about like electrolytes that much. And like in terms of like what you see on electrolytes are like bread and butter.
Yeah, I just had to teach it from like the Oxford Handbook, the clinical chemistry section. It's not even in the endo section. Like,
yeah, it's a nightmare, that section.
It's not ideal.
We save it for like berries so that they can ask those questions in 5th year, but I don't know if that's true.
Yeah, no, yeah, I've heard that too. Yeah, that's a good point. What are you thinking the answer may be?
Anyone? Any suggestions?
Any thoughts?
Or does anyone have any idea what the diagnosis might be, or like what's going on?
DKA maybe?
That's a good suggestion.
Or like hypercalcemia.
Which one? Sorry, what was that?
Hypercalcemia. Was that
hyper? No, sorry, I just can't hear you.
Yeah, I can't remember. I think it's hyper.
Yeah, that's correct. Well done. So this is hypercalcemia. Does anyone know what the most important initial management of that is?
Fluid resource. If that's
yeah, well done. Yeah. It is. Oh, is someone?
Yes, that is the classic Jordan Crohn's.
Yeah. That's the.
I just always get it confused with hypo, so just wanted to check.
Yeah, I know. I think it's quite. I'll go on to the all the mnemonics for the various things, but yeah, that's right. That's one for hypercalcemia. So you are correct. It's basically dehydration is the most important thing. It's like the most acute thing that's going to happen if someone's hypercalcemic. So they do quite aggressive like fluid resuscitation. They normally give them like 3 to 4 liters a day. And so initially you always want to, and even if you think of like A to E assessment, something like fluids is always going to come first, isn't it? And so also it promotes them kind of like peeing out the calcium. And then basically furosemide is a bit controversial because it can actually worsen their electrolytes that are a bit screwed up. So you wouldn't really do that. And then we'll come on to the other ones because those could be options for management. So well done.
I was just going to say, so I think DKA is a very, very, it can present in a very similar way to acute hypercalcemia. So like before you did this, so if you were to work up this patient, what is the first investigation you would do? Just clinically, what do you reckon you would do?
Blood glucose.
Yeah, you'd start with a blood glucose, and you'd probably do like a VBG because I'll give you like a ionized calcium as well. So you basically hit 2 birds with 1 stone. Important to emphasize, with anyone with like lethargy, you do blood glucose, but now you also do blood ketones. You do both in A&E. So just worth remembering that. Sorry.
Glucose, no, it's fine. It's an important point, and glucose is such a classic. They always want you to remember glucose. If you know the A to E mnemonic, and then it's like don't ever forget glucose, like D, E, F, G. So like always remember glucose is always it's like that's part of your A to E assessment. It's so important. So that was a really good suggestion. I can't remember whoever said that DKA, but that's a really good differential to have. So I'm just going to kind of go through a bit of calcium homeostasis before we do it, because I think it helps if you understand kind of like what goes on, where it's absorbed and things like that. So calcium is actually the most abundant mineral in the body, fun fact. And 99% of it, like most of it, is tied up in our skeleton. And we basically intake about 25 millimoles a day. So the thing you need to remember is that there are like basically 3 main sites that you want to remember where calcium exchange, like kind of absorption, secretion, like getting rid of it happens. So obviously the kidney, you have it filtrating out or you're reabsorbing it. In the GI tract, it's really important. So we'll come on to it, but like various hormones and things can cause increased absorption in calcium in the GI tract. And also bone. So like forming bone, resorbing bone will have an effect on your calcium levels. So a thing that's like talked about quite a lot is corrected calcium. And it just comes up, I think it's just good to have an awareness. Basically, if you think of the total calcium in your plasma, it's basically split up into these three things. So protein bound, complex, and then there's 50%, which is free. And that's the part that's important because that's what we like regulate in our body. And that's basically what we're interested in. So when you do a routine lab measurement of calcium, they're actually measuring the total plasma calcium. So that's including the albumin bound and the complex, which are kind of irrelevant for homeostasis. And the whole thing about corrected calcium is that basically albumin can affect your total calcium, but it doesn't actually affect the free calcium, which is the calcium part that we're interested in. So we do a corrected calcium, which basically means they adjust for the albumin so that you can get a more accurate measurement of the free calcium. So that's just an important thing to remember, is that you're more interested in corrected calcium because it's not been affected by the albumin levels, basically. Just remember that. Okay, so lovely throwback to, I think this is like second or first year bio, which is lots of fun. But basically our serum, the things that control our calcium is parathyroid hormone and vitamin D. And like I said, those three areas, the kidney, the bone and GI tract, are where these things are important. I think that's quite a good diagram, to be fair, to show like where it's absorbed. And so like the effect of PTH basically. So it kind of, vitamin D, the most active form, which is that thing there, is calcitriol, and that basically overall increases your intestinal absorption. So vitamin D is acting, which I'm sure we all know, increases calcium, right? And also to do with PTH, we'll come on to that a bit later actually, so I'm not going to go into that huge amounts, but just be aware that PTH and vitamin D are important in affecting like the levels of calcium in our blood. This is actually quite a small diagram. You'll be able to see it on the slides after, but this actually really sums up like all the enzyme changes. I don't know if you need to know this, but I just think with vitamin D, just be aware. I think it's very important to know that there are different parts where we're activating vitamin D because it's relevant when things go wrong in these organs. So if you have liver failure, it will literally have a knock-on effect on calcium homeostasis, which you wouldn't even think, because of the fact that one of the conversion steps happens in the liver. And then the kidney, if you guys have done renal endo, like I'm sure you'll be aware, like CKD is really important because the kidney is the final step. That's where we convert it to calcitriol, which is the active form of vitamin D. So obviously if your kidneys aren't working, you're not going to be able to get that final form. And then that's going to have a knock-on effect. Just to mention, calcitonin decreases serum calcium, and that's released by cells in the thyroid gland. And yeah, just like I said, the bones, the kidneys and the GI tract are basically the main organs or areas.
It's worth emphasizing you do not need to learn all of this diagram.
No.
As Dhivya said, yeah, know what like the hormones kind of do overall, and know that the kidneys are you see the top bit where it goes like skin, liver, kidneys. That bit is also like key. Yeah. So know what the hormones do and know where vitamin D is like activated, because it's like a classic exam question.
Yeah, they do like this is like the one biochem thing they probably do like. I just think if you're confused, just like I think this diagram is good at just saying the overall effect it has, but you don't need to learn like, you know, rote learn it. Okay, so can anyone think what are the kind of main causes of hypercalcemia? There's like 4 big causes. Any suggestions?
Hyperparathyroid.
Yeah, that's one big one.
Which ones?
Primary and tertiary, right? Or the
yes, exactly. Not secondary.
Nice.
High vitamin D.
Yeah, vitamin D intoxication is, of course,
Myeloma?
Yes, so that could come under malignancy, exactly. And then one kind of row condition that UCL absolutely love comes up in RESP as well.
Sarcoid?
Yeah, well done. And also another cause, everyday things that patients take. just drug causes basically. So there are certain drugs, so thiazides, and definitely remember about thiazides causing hypercalcemia, and lithium also can cause that. So I kind of listed a bunch of the causes. I think these are the four ones I put in the box are just like big causes. Primary hyperparathyroidism and malignancy account for like 90% of hypercalcemia. But sarcoid and drugs as well, just it's important to be aware of those. They really like knowing the electrolyte side effects of drugs. And then, like you said, vitamin D intoxication. Also, I think it is important to remember these metabolic conditions. Addisons, like the fact that it causes hypercalcemia is like not many people just like kind of don't really acknowledge it because they're thinking about the sodium and the potassium, but it's important to know that Addisons can also cause high calcium, and also increased thyrotoxicosis basically it also can cause it. Does anyone know what, this is like a bit niche, don't need to know, but does anyone know what familial hypocalcemia is? It's very rare.
It's in the
Is
name.
it something to do with receptor? It's like a receptor sensing of calcium goes wrong, and then you end up keeping the calcium in and not peeing it out.
Yeah, exactly. Yeah, it's literally exactly. It's a inherited disorder. It's also more dominant. It is really rare. Also, usually people don't actually have symptoms. They're just kind of routinely do a blood test and they have high calcium, and literally like it says in the name, like hypocalcuric, so there's less in their pee. But like you said, exactly, like they have high levels in their blood. Just to be aware, that's a random thing. I don't know if that would ever come up, but that is a cause.
Just like refresher, what's like the classic electrolyte abnormality in Addisons? Because this is like again a classic exam question. We might as well talk about it if it's on the slide.
I know you get hyperkalemia.
Hyperkalemia and
hyaldosterone.
Hyponatremia.
Hyponatremia and yeah. So anyone with a high potassium and a low sodium is Addison's until proven otherwise. Because Addison's, like, you might have heard Ahmed make this joke, but Addison's is like the master of non-specificity. Like if you don't think about it, you'll miss the diagnosis, and like Addison's can kill. So high potassium, low sodium is Addison's, like until you've found evidence of something else.
Yeah, that's important. I think, yeah, it's so vague, the symptoms, like abdominal pain, like it's very random. So you just need to be aware. I think that's common with a lot of the metabolic things. So if you're really struggling in a question, you can't figure out the stem, like just even literally go through electrolyte abnormalities. I think, could it be something to do with that?
Yeah. I actually, yeah, any time there's a set of blood results and there's U's and E's, the first thing I look at is high potassium, low sodium, and then I move on from there.
Yeah. Because Addisonian crisis and stuff, if you've done endo, like it's an important emergency to be like know about, and the management and stuff. So I think Jordan, you already put the little mnemonic in for hypercalcemia. So does anyone know what like kind of symptoms that would be? Like that's, I mean, I know it's like that's a mnemonic, but does anyone know what kind of stuff that would manifest as? Some of the symptoms were in the stem I gave you in the SBA. So like
Bone pain.
Yeah.
Urine, like stones, kidney stones.
Yeah.
Depression. Abdominal pain.
Yeah, exactly. Well done. So with the psychic moans, it's like just a range of basically psycho symptoms, which are like lethargy, confusion, like things like lethargy, and when they're getting into a coma, obviously that's very severe. That's like they've had hypercalcemia for a while. They might just be irritable or have low mood. You get abdo pain, vomiting, constipation. With bone, you get bone pain, especially with something like malignancy, and also you can get ectopic calcification, so like on the eyes. And then the stones, kidney stones, you can get renal failure if it's severe, and peeing a lot, being really thirsty. And then just random extra symptoms, you can actually get fever and hypercalcemia, and also high blood pressure. So yeah, literally this is actually one of the most useful mnemonics that actually you just can remember. Oh, sorry, did I cut out?
I don't know whether it was you or me.
Did anyone?
I think I heard it fine.
Yeah.
Okay.
Oh, right, it was me then. That's
okay.
fine.
I think, yeah, this is actually one of those mnemonics that like literally just learn it. It just is what it says on the tin. Like you're going to remember that from that. Okay, there's just one abnormality. You don't need to interpret the whole ECG. Anyone, this is to do with hypercalcemia. Does anyone know what is wrong with this ECG? Just the overarching problem.
Short QT interval.
Yeah, well done. So with hypercalcemia, you get a shortened QT interval. That's why with these patients, it's important that you do an ECG. Okay, so calcium and PTH, if they're both elevated, then the cause is going to be primary hyperparathyroidism because the PTH is pushing up the calcium. If the PTH is normal or low, but you have high calcium, then you need to explore that it could be a malignancy, basically. ECG, because of shortened QT. You'd also do a bone scan, especially if you're suspecting malignancy. And some extra things you might do. So the 24-hour urinary, that would be for the familial hypocalciuric hypercalcemia. If you're suspecting that, you're going to do creatinine in case they're an AKI, like if they've got an acute kidney injury from the high calcium. Why might you do a chest X-ray? What cause are we thinking about there?
Sarcoidosis.
Yeah, and does anyone know what the classic sign of sarcoid is on the chest X-ray, which UCL love?
The clue is lymph nodes.
Yeah.
Say that again.
Like lymphohyalinopathy. I can't remember the words.
Bilateral hilar lymphadenopathy. Yeah, so like the hilar are like really what's the word? Like enlarged, basically.
Massive. They're massive. What other conditions can cause like hilar lymphadenopathy? If you were to think about it.
TB.
Yeah. What else? One other big thing. Well, one category, two things.
Cancer.
So in the lung, the two important cancerous causes are lung cancer, which is usually one-sided, or like lymphoma, which might be both sides. Yeah, that's like a useful list to know, actually.
Yeah, learn the differentials for bilateral, or just hilar lymphadenopathy is worth learning. What could cause that?
Would lymphoma be bilateral? Sorry.
So it depends. So Hodgkin's is more likely to be unilateral. Some forms tend to be bilateral. So it's difficult to say. It could be either. It's not. You can't.
A sign of malignancy.
Yeah, just know. Yeah, as long as you know that it could be a cancer, then you're doing well.
Sorry.
It's all right.
No.
And then vitamin D, of course, because Vit D intoxication can cause hypercalcemia. So these are just like extra investigations you might do, but obviously important that you do calcium, PTH, and you definitely want to do your ECG. So management. So I said, obviously we gave the saline first. Does anyone know what else we do to manage hypercalcemia? What other things we would give after we've rehydrated?
Bisphosphonate.
Yeah. Exactly, well done. And then if the patient has sarcoid, what might we give them? What drug do we give for sarcoidosis?
Is it Pred?
Yeah, well done. And does anyone know the like side effects of bisphosphonates is such a big thing? Can anyone like list some side effects? So like
bone osteoporosis.
Yeah, so you can get low calcium on the other side of giving them bisphosphonates. Yeah, and then also just another thing of like them feeling like a more common thing is them getting flu-like symptoms from it. So just feeling really unwell on it basically, which is a bit shit. But and you can get bone pain, myalgia, nausea, vomiting, all those like non-specific like headache. Also they can actually cause low magnesium as well as low calcium.
Sorry, just one thing. I don't know what someone said, but I heard like osteoporosis. So yeah, these are also used to treat osteoporosis in elderly people, especially women, because they lose estrogen after the menopause. So yeah, bisphosphonates are good for osteoporosis. Do you know an important thing for OSCEs is? Do you know how you would take up this? Sorry, you're going to cover this, did you?
No, not. This is important.
No. Yeah, so like if a patient's going to take a bisphosphonate, do you know what you would tell them? Do you know how you would tell them to take it? You might have heard of it. If you haven't, don't worry about it.
Isn't it something like 30 minutes before you eat, and it has to be standing or sitting upright or something like that?
Yeah,
Yeah.
so stay upright 30 minutes before breakfast usually, because you can get like esophagitis, because it's really acidic. It's really bad.
So you have to take lots of water as well.
Yeah.
But on an empty stomach.
Yeah, and importantly, if a patient gets severe reflux despite taking it correctly, you need to switch them to a less acidic one. So like you might switch them to if this is for osteoporosis, if you're taking it orally, you have to switch them to like a less acidic one, and then if they still get it, then you need to switch them to IV or like some other things. I have a read about it. It's quite like, I think counseling bisphosphonates is a potential OSCE topic.
Yeah, they could easily work that into an osteoporosis station or something like that.
Yeah, they love osteoporosis.
Yeah. Okay, good. So that's management of that. I've got now another SBA, the fun little X-ray. So if you just take a bit, another two-step classic.
This is a great spot diagnosis that you see. You might not have seen before, but once you see it, you won't forget it. Any
So
ideas?
does anyone know what the hand X-ray is showing? Or just what's abnormal, like what looks weird to you?
Is it the bones are broken down at the top?
Yeah,
On top of fingers.
the distal phalanx, they look like they've been resorbed, like they're less of them. It's been broken down, exactly. So if you don't know the cause, can anyone think of what the diagnosis might be, based off the bloods even?
Maybe hyperparathyroidism?
Yeah. So this is primary hyperparathyroidism. And then basically it's just requiring knowledge of like what the most common cause is of primary hyperparathyroidism. Does anyone know that? What accounts for most of the primary hyperparathyroidism?
I think it might be adenoma, but I don't actually know.
No, that's right. Well done. So the solitary adenoma is like 80% of primary hyperparathyroidism. So also the symptoms, we'll come on to it, but the symptoms are basically symptoms of hypercalcemia again. Just so if you link that to the first SBA as well. And the bloods, and it says like mildly raised PTH, because in primary hyperparathyroidism, the PTH can actually be like weirdly normal, despite the calcium being high, or it will just be like slightly raised, but you still have to consider that it could be caused by like the hyperparathyroidism. And this sign is called acroosteolysis. It's like on the notes inside. It just literally means osteolysis, like the bone's been broken down at the end of the phalanx, and that's a sign in primary hyperparathyroidism. Just like a fun spot diagnosis.
Does anyone know what? So if someone presented with small joint pain and this X-ray, do you know what the diagnosis would be? You might not. Don't worry if you don't. So there is a condition you'll learn about in Module B that can cause this exact same picture, but with the different, like they wouldn't have like the hypercalcemia symptoms. So if I said small joint pain in the hands, what kind of conditions can cause that?
Gout?
I take it. So gout tends to go for the feet or like the knee, so less likely.
Like rheumatoid arthritis or lots of inflammatory.
So like an inflammatory arthritis, and specifically psoriasis, notably can cause this exact same acroosteolysis, and it's worth remembering, because they could give you an image of it and be like, oh, this person has small joint pain, what's the diagnosis? And psoriasis could be an answer, but yeah, in this context, it's obviously hyperparathyroidism.
Would their hands look different, like not on X-ray, but in real life?
If they have psoriasis?
No, in this case. Sorry.
Oh, as in, Oh, in real life, what would their hands look like? Their hands would look normal in real life because you can't actually tell.
With psoriasis, you can get this thing called arthritis mutilans, which is where their hands are like really badly affected by the arthritis, and then their physical clinical hands would look different to you. They look really awful and uncomfortable. And you would definitely be able to see that. But with this, just something like this, you wouldn't necessarily see that unless you've done an X-ray on them, because it's just a very tip of their finger. Yeah. Okay. So basically, I mean, I've listed the causes on the other side. It's just to show you that it's important just to have an awareness of like what generally is going to cause, like carcinoma only accounts for like 1% of primary hyperparathyroidism. And most of it is just like a solitary adenoma on the parathyroid gland, like secreting a lot of PTH, basically. So just have that in the back of your head. I think it's important to know the causes of it. So does anyone know what overall PTH does to calcium and phosphate? Like, does it raise it, lower it?
Raise calcium and lower phosphate.
Yeah, exactly. And it also has an effect on osteoclast. Does anyone know, does it increase osteoclast activity or reduce it?
Increase it.
It increases it, yeah, and it releases more calcium into blood, exactly. So basically, increase osteoclast activity, which are the ones that are like, osteoclasts are the ones that break down bone, versus osteoblasts, which are the ones that like build it up. And then you release calcium into the blood, and they reduce the reabsorption of phosphate from the kidney, but they increase reabsorption of calcium. And again, so that's calcitriol. So they increase the activity of vitamin D, which in turn increases calcium. So overall, it's just important to know that overall you get high calcium from PTH. That's what it does. It increases calcium and it reduces phosphate. That's like the main thing you need to know from that. So again, I'm just going to go through the symptoms because it's basically hypercalcemia symptoms. It's the same kind of like mnemonic of bones, stones, groans, psychic moans. But also just to know that primary hyperparathyroidism is actually normally asymptomatic. You don't necessarily actually just have someone presenting like in that SBA. Like it can just be randomly found when they have raised calcium on their bloods, like that other familial one. And so in terms of investigation findings, you're going to get raised calcium and raised urinary calcium, low phosphate, because like we said, it pushes down phosphate. And just to be aware, like they really like to just give you a normal PTH and it's still hyperparathyroidism. So it's not always going to be raised, and they'll just give you other clinical features which like they want you to then find out, which are then like you're meant to infer that it's because of the high PTH. Like the phosphate might be low in the bloods, even if the PTH is like weirdly normal. So it can present like that. You get raised ALP because you've got this increased osteoclast activity. Oh, I've put two of the same things there, just to hammer that home. And then investigations, you want to do X-ray and this scan, which I'll show you on the next page. So this is a scan on the left. It's just basically showing increased uptake. Does anyone know what the sign is? That skull X-ray, what that's called? There's like a little phrase for it.
Pepper pot?
Yeah. So it's just basically because you get resorption of the bone. So you get these like kind of lucencies, and it's meant to look like when you've like sprinkled pepper on something. There's also in multiple myeloma, looks basically exactly the same. Does anyone know what they call it for multiple myeloma?
I get this wrong every time.
Yeah.
Because I always get them confused. Does anyone know?
What it's called? So for multiple myeloma, it's called a raindrop skull. I think it's a bit arbitrary, but like you should just know that they use pepper pot skull to describe primary hyperparathyroidism, and raindrop skull for myeloma. You can Google it. They look extremely similar because in myeloma, it's also from lytic lesions in the bone. But I've always found it really hard to differentiate. I just think just know that they're using raindrop skull normally when they're referring to multiple myeloma.
I think raindrops are meant to be slightly bigger is the logic.
Yeah.
And in myeloma, they're bigger lesions. But like, if you can tell them on an X-ray, you're a much better like budding radiologist than like I am.
Yeah, I could never tell on an X-ray. But I think Pepper Pot Skull is just like classic buzzword. Just like remember that it can cause that sign on X-ray, on skull X-ray. What's the definitive management of primary hyperparathyroidism, bearing in mind what the most common cause is?
Surgery, parathyroidectomy.
Yeah. So generally, the way to like just actually get rid of it is to just get rid of the parathyroid glands on the thyroid, basically. So there are some times where you can just give conservative management. So you can give something like Kinacalcet, it's basically a calcium mimetic agent. If they're really like old or frail, or they're just not appropriate, there's something contraindicating them from surgery. And yeah, those are the terms of basically when you would give them calcium instead. So what complications are you going to get if you give them a total parathyroidectomy? What might happen? It's like a couple. There's a nerve that runs alongside it that you might damage in the surgery.
Is it laryngeal nerve palsy?
Yeah, the recurrent laryngeal.
Recurrent laryngeal.
Yeah,
so they
exactly.
get like hoarse voice, that kind of stuff.
Yeah, exactly. Hoarse voice. And obviously go the other way because you don't have a parathyroid gland, you're going to get hypoparathyroidism. And then as a result of that as well, you might get actually the symptoms of hypocalcemia. Just remember, I think like recurrent laryngeal nerve, like someone having a hoarse voice is just like a classic complication. Like, and they're like, why is that? And it's because they've had a parathyroidectomy after. Just to bear that in mind, I think. Oh, and another SBA for you.
This is a great question.
I took so long finding all the other SBA options. We'll go through what each of them are, but does anyone know?
I think it's D. Is it D?
Yeah, exactly. Do you know what sign that is? What it's called?
It's either Trevostek or the other one that I don't remember the name of right now.
So sorry.
True
So
sign?
this
No, that's the blood pressure one.
Yeah, so this is Chostek, I can't say it, Chostek sign. So literally I've basically got PTSD because in my second year final OSCE we had like a whole calcium station which everyone in my year bombed. The average for it was like 20%. Like everyone did so badly, and they just absolutely just so much of the station was about signs of hypocalcemia. So these symptoms are hypocalcemia, just so that's a diagnosis. And yeah, the sign that and I think it is just actually important to know what it means. Like people just learn like the name of the sign and don't actually know what it is. So does anyone know what Trousseau's sign is?
Is that the blood pressure one where they put the blood pressure cuff on, but instead of it going, however it said on there, it comes like upwards and their fingers come together? Is that right?
Yes, they like flex. They get like spasm
Yeah.
and then go down like that instead of extension. And just to go through the other signs, does anyone know what the other signs are showing? So obviously C is just not correct because it should be flexion, but A, B, and E, does anyone know what any of those signs are or what you'd find them in, even if you don't know the name?
I'm just guessing at these hypocalcemia signs.
So the rest aren't actually to do with calcium. They're just like
Okay.
they're like ortho conditions.
Got
I've been a
it.
bit.
I think A is carpal tunnel. Is it carpal tunnel?
Yeah. So tapping. I just remember tapping tinnels. So it's called tinnel sign, and you like tap repeatedly over their carpal tunnel, and it just reproduces the kind of paresthesia over their hand where the median nerve supplies. And anyone know what B is for?
Is that the Fallon's test?
Yeah.
So carpal tunnel.
Yeah. So it's like you make them hold their hand like this for like 30 seconds or a minute or something, and it reproduces it because you're trapping the median nerve again. So A is Tinnell's, B is Fallon's, and they're both for carpal tunnel syndrome. C would be Trousseau's if it was wrist flexion, and D is what is correct, which is Chostek's, where you tap here and their like mouth like twitches up. And then E, this is a bit more niche, unless if you guys have done ortho very well, does anyone know what that is?
This is a challenging description. I just had to do it before I realized what you were talking about. It's like this. It's like this, basically.
Yeah.
If you can see my hand. Do you know what this where basically you hold your thumb in your hand and then ulnar deviate
So
the hand.
if this is a patient's hand, yeah, the doctor holds their hand and goes like that, and it reproduces ulnar
Yeah.
deviate.
Is it Finkelstein's? The for teenage synovitis.
Yeah, very good knowledge. Yeah, so it's called Finkelstein's test is where the examiner kind of pulls it, and then they get pain over their distal radial styloid, and that's in De Quervain's tenosynovitis. Exactly. These all sound a bit like random if you've not done them, but these are actually signs that you should learn. Just be aware of that when you get to ortho. I would learn the names of that because it's like also quite easy for OSCE stuff. No worries. Thank you for coming. Yeah, so tapping on the ear in front of the ear causes facial spasms, so their face kind of like spasms upwards. So we can split basically the causes of hypercalcemia into conditions where you're going to also have raised phosphate and then where you might have normal or low phosphate. So does anyone know what causes of hypocalcemia with raised phosphate?
Secondary hyperparathyroidism.
Yes. Yeah, I think, is that right? Yeah, I'm trying to think about the parathyroid.
So you have appropriate increase in PTH to compensate for a low calcium in secondary hyperparathyroidism.
And then does their phosphate also go up?
What does PTH normally do?
PTH normally lowers their phosphate, doesn't it? But I can't remember which way around it.
I can't remember. We'll find out in a minute. It's not that important. This is less important than the high calcium.
Yeah, hypocalcemia is definitely not as important. Basically, CKD, remember that you would also get a raised phosphate because basically the kidneys aren't working as well to excrete it, is the way I think about it. Hypoparathyroidism, you would also have raised phosphate. So after like a parathyroidectomy or something, pseudo hypoparathyroidism. I haven't gone into all the like parathyroidism because there's quite a few, but it is worth learning them, or like the different signs for it, like secondary pseudo, and then there's like pseudo hypoparathyroidism, and rhabdomyolysis. So someone that's had like a long line and their muscles start wasting, and also just hypomagnesia. These aren't really. I don't think these are really that important. Like I don't think you're going to be like asked. But it's just, especially something like CKD, it's important to know that the abnormalities you're going to get with that. And vitamin D deficiency, so osteomalacia, which you do in ortho, I think, can cause it, obviously. So yeah, those are just some of the causes for your interest. This is just another diagram just to like help you kind of remember. If you've got what happens, you've got low calcium in your blood, your parathyroid glands respond by increasing PTH release. And that acts on the bone, like we said, it increases osteoclast activity and releases more calcium into the blood. And it would also act on the kidneys to cause increased reabsorption of the calcium to raise the serum calcium. And then your active final form of vitamin D, which remember you get the vitamin D converted to its final stage in the kidney. Then that goes on to act on the intestine and increases absorption of calcium. So that's just like a little summary of what happens with it. Does anyone know what the mnemonic they normally use for hypocalcemia is? Or does anyone know any symptoms of hypocalcemia if you don't know the mnemonic? So that's the mnemonic. Spasmodic. It's funny because
I didn't know this until like I looked over your slides a couple of days ago.
I learned it's in the Oxford Handbook. I remember learning it from the handbook, but it does have like a lot of causes here which you just don't need to know. Like it's more extensive than the hypercalcemia one, whereas I actually think hypercalcemia is more important to learn. Yeah, that makes sense. So high phosphate if you've got CKD because your kidneys aren't working to excrete the phosphate. Okay, so these are just some of the symptoms. So definitely like perioral paresthesia, so like numbness around the mouth is quite like one that they like to use as a sign of hypocalcemia. So definitely remember that. Again, you can get like sight disturbance, you might be a bit irritable. Seizures is also common to hypercalcemia. And then S, obviously the spasm. So the carpopedal spasm with the blood pressure cuff is troposine. And then spasmodic, obviously, like think about muscle tone. So you get increased tone. And it can actually present, I think it'd be a bit mean if they presented like this, but like you could have someone having wheeze because the muscles in their like trachea are spasming, but that would be a bit mean, to be honest. Yeah, and then these other ones are a bit rogue. Chostek sign is fair because that's the one where you're tapping. And again, it's the opposite of with hypercalcemia. You actually get a long QT interval in hypo. I just think it's the opposite of what you think. So less calcium, you get a longer QT. High calcium, you get a shorter QT. It's lower. So just be aware of that.
Yeah, definitely focus on like the neurological / muscle things, because that's what they love putting into exams.
Yeah.
The other stuff is like a bit too, it's a bit niche. So like, yeah, if you're gonna focus on that.
Does anyone know what you do to manage it? What drug you give to replace their calcium? You give this in hyperkalemia as well.
Is it just calcium gluconate?
Yeah. So you give IV calcium gluconate over 10 minutes. And if it's really mild, then you can just give them calcium tablets to take like 3 times a day, but you need to like regularly check their calcium. But realistically, if you're on an SBA, like they're going to need IV calcium gluconate, like they've come in an emergency probably. ECG monitoring, again, really important because of that long QT. And if they've got CKD, you're going to have to give them alpha calcidol, which is active vitamin D, because like we said, you're converting into the final form of vitamin D in the kidney. So if your kidney's not working, you won't have that. So you have to give them just the active form. You can't give them one of the earlier forms of vitamin D because they won't be able to convert it and it will be useless basically. So that is like, especially in renal, that's such a thing to remember, that you give them active vitamin D if someone's got kidney damage. Yeah, so that is basically just a quick stop tour of calcium and vitamin D things. Does anyone have any questions about anything?
It doesn't even have to be related to this.
Yeah, anything?
So do you think it's important to learn about the pseudo, you know, those bits, pseudo hyper, that, you know?
I think I can't remember what I learned about.
I mean, you know about the finger sign because they love asking about the 4th and 5th digit sign. You see, like, yeah, with like niche conditions, what I normally say is if you can summarize it in like 2 sentences, that's probably enough detail for your exams.
I remember for pseudo hypo, I don't think I learned the pseudo, but like for the pseudo hypoparathyroidism, basically, I just learned the PTH level and calcium, and then just the fact that they have short 4th and 5th metacarpals. That's just like a sign that I remembered for that because it was just like one thing to pin it to. I mean, the thing is, realistically, it's like if you have time to learn the niche stuff, then do it a bit closer to exams. You might get a mark, but realistically, it might just not come up ever. So it's if you just focus on the main things, because that's what's going to be tested. Like the common things are going to be tested more. And then if you have time, like Anish said, you don't need to learn it in detail at all, just like some facts that you can think about, I think.